Awesome. Well, we left off with the trauma in the brain video. So we will wrap up just a few more notes on responses to trauma and kind of how that might come up in the work that you do, you might see, and then get into some different practices of trauma-informed care and how you can show up. The fight, flight, freeze, and fawn in the moment happening when trauma is happening, and then they might also show up again if that trauma is queued up, if it's prompted in some way. The cortisol over time, we did talk about the compounding effect of having more than one traumatic experiences, or if abuse is ongoing and it is repeated. So the body can undergo that stress one time, and that is an impact. It can also, if it goes under multiple times, have even more or like more intense disruptions in how it's functioning. Some sense of feeling disconnected from a newborn. So if this is a new mom, a parent with a trauma history, there might be that kind of disconnect. One survivor had talked about not necessarily feeling very connected, as though she was pregnant, and then all of a sudden it's like intellectually she knew obviously there was a baby going to be born, but when it actually happened, it seemed kind of all of a sudden that it happened, obviously not out of nowhere, but it was a one kind of way that shows up in not necessarily connecting to the whole process, but of course going along with that. And sometimes the responses to trauma will be things that you don't necessarily expect to see. And so where kind of like the example I was giving of someone who might be very fatigued and not have a lot of energy, someone would think, oh yeah, well, you just went through a really like horrific thing, or like that's in your history and this really brought up a lot. The person might rather experience having a great deal of energy. So it's just a matter of like systems being kind of off after that. And we all kind of figure out, our bodies all figure out how to regulate in a kind of different ways, different trajectories there. Next slide.
Oh, Jessica, there's a
Yeah.
question in the Q&A.
Oh
From
yeah.
Michelle, she said, do you know of any research or studies on women who do not know they are pregnant and trauma?
I do not. I'm familiar with stories of when women didn't know they were pregnant until like then literally there's a child being born. Surprise. I have seen the show also. Um, with research, I don't. Are you, Sandy, aware?
I'm not familiar with any research on it. And that's a point that I think is across everything we're talking about today, with just talking about maternal health and reproductive health. There is not enough research done, period. So I think that's a good point in an area that we need some more attention.
Yeah, absolutely. Michelle.
That was me that put the comment, because in the last slide when you said like the disconnect, right? There's like an emotional disconnect potentially from the child. I would be so curious. I wouldn't be surprised if there's some correlation between trauma and then the full disconnect of being, maybe obviously not for all women, but like some of the women who have, I don't know if they call it pregnancy denial, I forget the right term. But that complete disconnection from the body of like not feeling move or giving other reasons for the movement. If anybody knows of anything, I would love, please pass it on.
Yeah, share that in the chat. If you all have heard of that, I could kind of see that in both ways, right? Of that response to trauma and the changes of the body, and really finding a way to I don't know, rationalize is the right word, but like to really create an understanding of what's going on that is anything but being pregnant. I can also see, think of someone who is pregnant and doesn't know it, and then they have this child, and how is a history of sexual violence then going to affect and interplay that, genuine surprise also. So, yeah, folks, share away. All right. So dialectics, if you want to, leave it there. Thanks. So, dialectics, is an understanding of a synthesis between things that seem like they're opposites and yet coexisting at the same time. So this might be, I think of times where you love your mother and then you also just are very angry with her. And it's like, how could she do this or say that thing? Where at the time, you're both angry and you do love your mom, as that classic example, I suppose. And so in much the same way, we can think of how trauma is people are affected by that and about being prompted and having these cues. So understanding this piece of this idea that, oh, I'm kind of expecting to see someone respond in one way, kind of keeping on the back of our mind that it might be the opposite of that as well, that they could be experiencing. So this first, think of each of these kind of on like a continuum that in the treatment that I do in DBT and in doing prolonged exposure, and recognizing these various different perspectives and expressions that might come of trauma responding. The idea there is to be able to find the balance in seeing there is some validity and recognition in both of these points. I think for you all, just knowing that if one shows up, the other might at a later date, or maybe one person is kind of more prone to be pulled in one direction or another. If we think of systems wanting to have homeostasis, the ideal is that there is a balance. When we enter trauma into that equation, it tends to bounce into an extreme. It goes kind of like off kilter until the body finds kind of its new normal, its new way of existing. So there might be times or there might be individuals that end up wanting to seek control over many aspects of their life, and being very rigid about scheduling, about like feeding schedule, or about visitors, or about things like in their own life, and wanting to have a control and understanding of all of the pieces, maybe even to the point that it goes outside of what is healthy or effective. And then there could also, then the opposite of that, be a disinhibition. So having, sort of the opposite of that, like no control, no rhythm, no sort of like patterns, just kind of maybe not even taking safety into consideration, maybe putting themselves into more dangerous situations, or doing like actions that might seem problematic, but they find a way of thinking, oh, well, I just think of, oh, I'm not driving that far. Do they really need to be in a car seat? Like, one would argue. So I think of like when trauma comes up, like that can pull a person into either having being not affected and interested in rules, or the other end where there is like this almost like over controlled, trying to control things that maybe are outside of their control anyway. The middle one relates to emotions. So how a person, this could come up where it's how they're experiencing an emotion, or it could come up when they're expressing it in a way. So someone might seem cold and numb and disconnected and not have really a lot of emotion going on, or not a lot of like feeling and love or connection in their mind. Or then could be the other way where there's so much emotion, there's so many tears, there's so much fear or love or like a lot that can also be really challenging then to kind of move throughout the day or explain a situation or tell a story or something like that if those emotions are so front and center. So you can kind of get that idea that if there's too much emotion, it's a problem. And if there's really not enough emotion, I guess, like not enough connection, that can also lead to some problems too. And then the third dialectical kind of continuum relates to engaging with other people and having relationships. So on the one hand is this, I can't trust anyone else. It's really me against the world. And I have gotten myself through life thus far, and it's just going to be me, myself, and I figuring this out. The other end of things, it might be I need all the supports. I need to have everyone in my life know all of the information and connect on all of these different levels and have people recognize and understand where I'm coming from. Maybe even to the point that they're connecting or they're sharing, maybe they're sharing with a home visitor, a parent coach that maybe is better for their psychiatrist or their therapist. And so that kind of goes into like the role of, no, I don't want to like put a person down for feeling open and safe to disclose certain things, and also recognizing that like maybe that's not like the right timing for that, whatever the thing is that they're sharing. So anyway, one or the other. So each of these things kind of might show up from time to time. Next slide. And I wanted to put one, I could probably make the claim if we had more than 8 hours to really dive into a whole host of emotions. But in particular, I wanted to just bring the attention of shame, where we have the emotion of shame in order for us as social creatures to remain connected. Shame shows up if we have the idea that if someone else or if this group of people who I might care a lot about were to know something about me that would ostracize me or remove me from the group. So shame is there to help keep us connected and in line with social norms and expectations. So if I'm doing something that goes against that grain, the emotion of shame activates me to kind of course correct and do something that is more in line. If I perceive that an action of mine or an experience that someone else did to me, if I am the victim, but in my mind, I'm in some way afraid that in some way I was to blame. And if people knew this secret about me, would they still love me and care for me and want me to be there? And so that can, of course, when either one, that isn't the case in fact, where parents and family providers are going to be there no matter what kinds of history this person is there, and they deserve to have the love and support of their community. So it might be in their mind, or it might be the fact that we do have rape culture, we do have social norms and certain expectations within different communities or in society as a whole that says that isn't an okay thing to talk about. That actually does say if you do talk about it, then you're not one of us. And so shame when it comes to sexual violence and sexual trauma, that it can be a really difficult thing to be able to speak up and overcome, both in relation to with other people, as well as just internally one's own kind of self and processing through this. So I think like in particular, shame is just a very intense emotion and can be really difficult to work through in therapy, but let alone just in day-to-day, obviously. So. All right, next slide. And then we have a few slides that I think are just going to touch again that you can kind of review on your own if you'd like, that we've given some examples of specifically survivors who are pregnant and parenting. So considering the impact on childbirth itself, on what it's like to be raising children when the parent has had the sexual trauma, different reactions during birth and postpartum that can be triggering, that can be prompting of that past sexual assault. It's not, and it's hopefully not a traumatic experience then, but certain parts of history can come into the present and make that be more so the case. Next slide. And then also when thinking about prenatal care, thinking about sharing full history with medical providers, not just medical, but all kinds of providers during pregnancy, and ensuring care for the infant afterwards. Having medical trauma, having sexual trauma, these can be big barriers to engaging and showing up to appointments and getting all of the care that is ideal for the mom and the baby. So advocating for trauma-informed responses and practices. That's why Sandy and I are out here doing all of the training and hoping that this can infiltrate on all levels of care and society. So one training at a time. And yeah, next slide. So certain characteristics, I think this is let me look at the next. Yeah, so we can go to the next slide. This is more of like a marker, switching gears. So what else can prompt trauma responses specifically around the realm of being pregnant and having and birthing, raising small kids? So reproductive coercion, this can be an ongoing. So let's say a new parent has had history of sexual violence. Maybe this is in her relationship, and there might be birth control sabotage, or there might be conversations within that relationship that maybe she wasn't necessarily interested in having another child. But there's certain power and control dynamics within that partner that would lead her to make the decision to or end up getting pregnant again. And all of these factors, of course, are not going to be forgotten by the pregnant person, and that can also hang over their minds during the process of pregnancy and birth. And there can also be sexual coercion if the person is pregnant or afterwards. And that also might be, additional layers of when a person may not feel comfortable, or they might not be medically ready to engage in sexual intercourse after giving childbirth. And so really thinking about the dynamics of the relationship, the intimate partner experiences that are present.
Yeah, and I just add here, this is an area where when we're talking about what people are disclosing and what information you providers have, having the pressure to have more children than you may want, not just a child, but more children is going to be another factor there. And this is challenging when you're at, in many ways, for survivors that are in violent relationships still, and maybe coming forward with a really brave face, so nobody's aware that that's what their experience is. And again, maybe it's because of a result of the this manipulation of birth control or things that Jessica said. But I think it's interesting and important to think about all of the manipulation that happens through these various means, and how much may always be going on behind the scenes, particularly when we see the overlap with domestic violence.
Mm-hmm. Yep. All right, next slide. And so through pregnancy and then after giving birth, there can be another added layer of what is that environment that that she's going home to? Is there going to be, again, coercive behaviors that are maybe happening there? Or maybe it's not, but again, because of the sexual violence history, being close and intimate and nourishing the child through breastfeeding may not be particularly comfortable. That could be something that is just ends up being not interested by the parent. And it might also be something that she would deeply want to be able to offer and to do, but it can be really hard even when working with lactation consultants and caregivers, support people, parent coaches. And to be able to like have that dialogue of the some of the reasons, and it might not even necessarily be on the new mom's radar and awareness of why it is uncomfortable or having additional fears or just discomfort with the experience, especially when it is something that she might want to do.
And I think
Yeah,
just the impacts on attachment in general, when, patients are feeling vacant or not connected to body, how that's going to impact that ability to what type of attachment is going to be formed from these trauma responses that the parent may be struggling with.
Yep. Yeah. All right. Next slide. So also related to domestic violence, there's a couple additional considerations as well. So after the infant is home, this is probably not new news, but there's going to be a lot of attention, and newborns need a lot of time and caring for. Obviously, they need round the clock attention. And that could be for a jealous or a controlling or abusive partner, father perhaps of the child, or maybe not. That can be another source of anger, another source of discontent in their relationships with him, wanting, usually a him, wanting more of that attention, and having that be really a particular struggle. And the comment of siblings as well. So think also, if there's been a difficulty with attachment because of trauma experiences, and there have been additional children. So there's older siblings that have also had a certain relationship with mom, and now mom is with the new infant. Then there's a whole other layer of how do you teach the older siblings about regulating their own emotions and being gentle and waiting their turn and having patience and sharing mom and all of that as well. So there can be a lot of challenges that are, then you have multiple humans, emotion systems at play and vying for that attention. And that's going to be stressful for any parent. And then again, to think of the layer of trauma and how that brain responds and manages stress. So not impossible, just, additional things to really take into consider and to understand if you're doing a home visit and there's a lot of these dynamics that are playing out and you're seeing that. So having that trauma-informed lens can, I think, be helpful in our own empathy and compassion and patience as well. Okay. Next slide.
Looks like
Oh.
there's a question.
Oh,
Have you seen any correlation with domestic violence and intercourse soon after delivery before mom is healed? Yeah, absolutely. Another means of that power and control, right? With just forcing oneself on because that's what the abuser wants, and dehumanizing the woman to see her as an object rather than, that autonomy and that basic human right. But absolutely, I think that is a common tactic.
I think, thank you so much. Because just from my observation, the 3 times, 2 or 3 times that I've had women who are having sex really early after delivery have
Mhm,
all been in domestic violence relationships. Now it's a small group, but
mhm,
it's been 100% of my observation. And so I think for our home visitors, keeping that in mind,
mhm.
because they do ask about birth control. And a lot of the times they ask and they're like, oh, I'm not even thinking about sex right now. But when I do, I'm going to talk to my doctor. But in the small chances that they're saying, well, yeah, I'm already intimate, it might be worth just considering what else is going on, especially if like you guys see that too, and if there's a pattern there. So I appreciate that.
Yeah, absolutely. I think that's a great point. And I think that it's another way that survivors are just disregarded by the abuser, right? Really objectified again. So I do think that's a great, wait a minute, maybe let's look a little closer here. Kind of red flag. Excellent.
Absolutely.
Yeah. So this is from also from the CDC. I will add that to the slide. I'm realizing it's missing, but some other things to think about in terms of prevention in general. So when we're talking a lot about social norms, how can we encourage more people to see something, say something sort of responses, right? And be able to do so safely, but think about that sort of collective responsibility, making sure that we're including men and boys in the work and expanding again that level of allyship. Um, we've talked about it's never too early to start teaching skills to prevent sexual violence, really encouraging children to believe that they have rights with their body, and making that again a more common just practice because it's not seen as taboo. That's how we have those culture shifts. And talking more about what is a healthy relationship, how do we help teens understand what is showing respect versus what is coercion or pressure. Really looking at how are we strengthening leadership opportunities? How are we making sure that families have the economic supports that they need? How are we focusing on strengths-based and empowerment-based, not only training, but opportunities and experiences? And I think there's a lot to be said for where else we need to provide some protection. Our schools, just look at the state of affairs in this country with people literally afraid to send their children to school. The violence in all these other ways that we're living in, and more proactive workplaces that have policies that are meant to be preventative and helpful, not only maybe thinking that paying attention to domestic violence or sexual violence doesn't really fall in their wheelhouse. And always being victim and person centered, really following the individual's lead, paying attention to what they are saying is what is most comfortable and, what they're feeling is necessary. So all of these opportunities for us to be trying to have fewer people in these situations in the future. Next slide. Okay, lunch. Let's take a second lunch.
I mean, I'd be up for that, but so getting into now trauma-informed care a little bit more. Shifting, this was, I guess we've been talking about this, that we're having this be victim survivor centered and not having it be their fault or making asserting an expectation that they need to have all the answers in a certain way or should have known something ahead of time. And I think that this like paradigm shift question, rather than asking what's wrong with you, like what's going on with you, you're different, of asking what's happened to you. What is it in the environment, in your experiences and people around you? Like what has been your experience? And having that focus, recognize that they're more than it's it isn't coming from internally. It's not something intrinsic within them. Next slide. Oh yeah, also, what is strong with you? Nice, yeah. And here's some guiding principles. You can look more on this. This is with the CDC and SAMHSA. Again, collaborating to put together 6 different facets, areas that communities can come together and increase in order to be more trauma informed in engagement and interaction, particularly with, with survivors, but with people who have experienced trauma. And yeah, just like the different disciplines. This is, it takes a village to raise a child, and really we all live in villages. We all live in different communities and different systems, and bringing in the peer support aspects of physical safety and intervention, giving choice and voice and empowerment to survivors, and really being able to pull in that kind of like the biggest ring of society, which is our ancestry and our the cultural practices, the history where we come from. So it can be on a lot of different levels. Mm-hmm.
Yes. I think here too, this is where we have to stretch a little bit and be reminding ourselves about trauma-informed approach when working with offenders as well. So we've been talking a lot about survivors' rights, as we should, but if we're really going to be effective in prevention, we need to help people not recidivate. And part of that is, as Jessica said, looking at trauma histories. So when it's not uncommon for offenders to have trauma histories themselves, and when those experiences are not identified and not intervened with, then we're more likely to continue to harm. So that doesn't mean we don't hold accountability as a important goal. But we'll again be more effective with our work with perpetrators too, and hopefully reducing harm if we're helping them address trauma they may have.
Mm-hmm. Absolutely. And from a cost perspective, we don't have a slide on this, but from a cost perspective for treatment of offenders as opposed to incarceration, the less expensive and the more effective is intervention, not incarceration. But yeah, that's also probably another talk.
And just the other hallmarks of the goals of trauma-informed work and practical applications are to reduce re-victimization and re-traumatization.
And Taisha.
I was going to ask about just the our prison and jail system. I imagine is very complicated working with certain populations. And sometimes it can feel like, or I imagine it can feel like, well, having empathy for the problem is wrong. And then sometimes you're shamed for that, but it's not holding someone accountable for what they did. But what I wanted to kind of ask you was, we do have families who, again, that may be recently incarcerated and may have histories, some of them being fathers, some being mothers, some, again, coming from different countries and cultures and value and beliefs. Mm-hmm. Any thoughts on, because usually our visits tend to be with the primary caregiver, the mother, and I understand this is what that's about. But any ideas on suggestions on how to, if there's nothing there, how to bring fathers who are there in better relationships that may have their own history, but want to share this moment with their wives? How do you, I know that's kind of complicated and layered, but
yeah, the starting point of it depends on what's the relationship with him and ostensibly the mother. so looking at that, but I think like, how would a person engage with someone who's had a trauma history and also been a perpetrator or an offender and in some way? And, I would say a lot of the same approaches are going to apply to the offender as the victim. There would probably be more focus on understanding culpability and responsibility and how to make amends and whose responsibility is it to or choice is it for reaching out for those apologies. So the focus on things might be a little bit different, but the underlying how a provider or support person would show up and be present with the person, there is going to be a very similar overlap, because you're going to be able to make a lot more headway in connecting with the person if you're leading with compassion and thinking about present and going forward. And my other thought, and people are more likely to change when they believe that you understand them and that you're there to support them. And that, again, I think that's going to be human. How that is from person to person might change that intervention. Like that's going to be their culture and their personality and where they're at and stuff. But yeah.
And this is reminding me about the work that is happening in the sexual violence fields, where people are finding that restorative justice practices can be supportive of healing when the right circumstances apply, right? When all parties involved want to be leading with compassion and truly doing it to address and validate and resolve some of these problems in ways that having that conversation and being able to have the offender, show some responsibility and some remorse, which often grows from being able to identify maybe childhood experiences they have had, right? So this again is the poly-victimization, and looking at locking up someone and throwing away the key doesn't do much other than lock them up and create more trauma. So I think trauma informed is about being open to innovative ways when consent is there to also try to interrupt those patterns.
Yeah, great question. Next slide. Actually, this is also again a fabulous segue here. So how do I respond in some way when someone is having how do I respond when they're responding to trauma? Just a little meta there, but initially without judgment, ideally, there's a time and a place to have a judgment, to place a value, judgment of right or wrong, accurate, not accurate. And we are all going to come with their own biases and filters that we see the world through because of our histories and such. And so to intentionally be present with the person, to let go or be aware if we're having judgments, and to do what we can to let go and engage non-judgmentally with that individual and what they're going through, and that their struggle is their own. Respecting privacy and pacing. So I think still to ask questions that need to be asked. If there is a red flag and you are concerned, is the current relationship that they're in abusive, definitely ask about that. And dialectics and everything here, that if they are wanting to be private and they're not wanting to share, then that is their choice. That is their right to share personal information with who they feel like sharing that with. Even if you might, as a parent coach, recognize that actually sharing all of this with the rest of the team is going to be really, really helpful, at the end of the day, they still get to decide whether or not, and also when to share certain things. And then we'll talk about being some active listening skills, which I think is also another training that's offered, but I'll at least touch on it a bit. So next slide. Another thing that can be very healing is being consistent, continuing to show up and be there and be present for a person. And so there might be times where someone was sharing that it's like for the first 5 years that you're able to be involved. There might be, I imagine, instances where it is a shorter time span where you don't have as many interactions. Maybe somebody moves. I mean, there a whole host of things. And so for the duration that you're there, if there is a commitment to showing up, doing so, even if they are not expecting it or maybe reluctant to it, it really is showing that you are just as committed to their healing and improvement and growth and all of this as hopefully they can be. And that is how trust and safety, like, can I count on you? When you say that you're going to help with something, is there a follow through? That is important. And of course, kindness, which again, it just really can't be understated. Having more kindness and compassion in the world with people who have sexual traumas. And just like the difficulty of adjusting to parenthood or to one more child. Every one of those steps is a whole new world. So really showing up and being kind goes a long way. To not underestimate that. Next slide. So I think this is also to recap. So the responses to sexual violence can be physical, sexual, emotional, mental effects. It's in the body, it's in the spirit, it's in the brain, and our emotions. There can be moments where there is that recognition of, okay, I'm feeling this way, or my body is reacting in this way because of the history. And then there might be times where the person, it's not clear to them that that's the case. And their sexual trauma can lead to a number of different disorders that you, of course, don't have to necessarily know or remember, but just recognizing that they're in much, maybe postpartum depression and mood disorders is a little bit more prevalent. It can be maybe even more exacerbated by also having sexual trauma and coping with that as well. Next slide. And trauma can also lead us not only to be, how do we process the experience that was had, but also processing a new sense of self and identity. And so family can be a part of that identity. If the relationship between that person and the abuser, or what family was like for the individual if they had experienced child sexual abuse in their own childhood, and having fears and thinking about what is the family that they are having and growing, what is that going to look like? There can be multiple types of abuse. So with sexual violence and sexual abuse, it might not only be that's happening. It could mean that there was psychological or verbal or physical abuse that was involved as well. And over time, there can be a confusion of, was this in fact my fault? Did I make this up? If I can't remember, if other people are not believing me, isn't it? It might make sense in their minds that maybe other people know better than me. That's what the abuser had insinuated or directly stated, and trauma kind of has our brain work differently. If you think of our brain like this, the kind of limbic system and our base of our brain that controls our drives to eat and to breathe and all of the kind of basic survival skills. And then we have the cortex on top, prefrontal cortex, handling logic and reasoning. And in society, there's an expectation that we are using our cortex, that we are thinking, that we are planning, that we are resisting urges and not going all spontaneity and willy-nilly all over everywhere, but that we are being mature in this way. And also making decisions based on multiple factors. When we have trauma in our history and we're cued and we're responded, our brain goes like this. So in order to have this come back down, that's kind of like the video was talking about addressing, like, how about present moment? Are you thirsty? Do you need a cup of water? Oh, do you have something to eat? Do you, what do you need in this moment? Are you comfortable in that chair I see you're sitting in? Things that bring it back down. Where, probably telling someone like, oh, we'll just calm down now, not going to help kind of bring that back down. And also with this being up here, it's very easy to recognize how like just initial like emotional drives and urges are going to be front and center. And so until that kind of calms back down. So there's your brain visual. Next slide. So with the brain being like that, or just having really stressful days, emotional dysregulation is your like $10,000 Scrabble word, if you could have that many letters on the board there, where your emotions are out of whack. So they're not regulated. They're feeling out of control. This can be a really intense thing, or it can be smaller. Typically, when there are trauma cues, it's going to be our emotions that show up, and they're trying to communicate. Emotions are also attempts at motivating us to act in order to get us into a place that is safe. So with trauma history, there might be just an added layer of having difficulty regulating emotions day to day, even when the experience isn't necessarily related to that. The idea of lower distress tolerance. So they might have less patients waiting in line at a grocery store. It might have absolutely really nothing to do with a particular sexual trauma, but the brain's ability and its effort and resources emotionally, like physically, chemically, might be lower, might be depleted, might be more affected by managing other stressors in life. Particularly if now, hi, this is a new parent, this is a new mom, and you have all of those hormones and changes. I think this is on another slide, but those hormones and changes, again, its own series of things to tolerate and get used to and have the body regulate again. So just keeping in mind, trauma makes everything slightly more complex and difficult. And so if someone's emotions really seem like they're kind of all over the place, that might be related to trauma. This isn't because the person's being difficult or intentionally forgetful or trying to manipulate the situation or things like that. Okay, next slide.
Jessica, I got a private message in the chat.
Yes.
This person's asking, what are some strategies to help home visitors when they may become disgruntled themselves during a visit, or they feel uncomfortable providing services with FOB, father of baby, or male identified caregivers?
Yeah, good one. We'll talk about some strategies that can be both for like sharing with the new parent, and they can also be things that you as providers, helpers, coaches yourselves can use generally, and also like in those moments and kind of what to do. So I think we will get to that. With regard to like if it's a specific client or a person that you've been like family you've been assigned to, and there is something coming up, I'd probably refer that back to have a conversation with your manager or supervisor about that, to see either if it's possible to swap out the case, or if there are some things that within the agency would make it more supportive for you to be able to have that, if it's like a different location or not going alone, or I'm not really sure. It probably would depend on each thing, but I also think about that. So like one part strategy intervention, second part talk with your employer.
Thank you.
Yeah. Next slide. A note here on the very top part says depersonalization and then derealization, and these are cousins of look there. These are cousins of dissociation. So again, probably more like clinical jargon that you may or may not really need to employ, but just to be aware. And hello, the internet. There's a lot of TikToks out there these days, so these words might be used and tossed out there. These are all relating to a disconnect from reality on kind of different levels, and this can also come from trauma. Again, this is our brain. This is our brain with trauma. So the disconnect that is happening is like the filter of our prefrontal cortex of our thinking has kind of been shifted or moved away in a sense. And so being able to see ourselves and connect with the world and what is going on in the moment might just feel a little detached. And so these are some of the words and concepts that have been researched and found through people's experiences. And so this might happen. Next slide. So again, some of the symptoms that we had talked about before of having a greater heightened startle response, being hypervigilant is like being really aware or alert to like surroundings. There can be a number of things that we've talked about that are triggers or prompts, cues that remind the person of trauma, whether, conscious or unconscious. Touch, closeness, physical contact can also be something that maybe that particular contact was not was innocent and it wasn't trying to be harmful, like if it was a hug or if it's breastfeeding, but it can still be a subtle or maybe not so subtle reminder of that. And then again, being able to just be able to find that closeness and trust and attachment with other people, with the family, with the new children. So, okay, next slide. And so some things that can reduce dissociation include therapy. So insert a referral to psychotherapist here. There's evidence-based treatments that are available, and VA and Medi-Cal and Medicare love evidence-based practices. So most of those are not a problem getting coverage. So that is good. And then addition things, I think referring back to the person, a lot of times they can be very creative and think of different ways that they see how help might be, like what might be helpful to them. Think about spiritual practices, cultural practices, different traditions in their communities, and some focusing on body sovereignty or kind of like taking charge, taking ownership over one's physical body can be a really powerful way of that empowerment and that post-traumatic growth. So if that is in some kind of like movement or weightlifting, it can be in massage, something that is more passive, just having there be touch and having that be, I liked what folks were talking about earlier with infant massage, which I'm going to go Google later. That was like, that's a thing. This is lovely. So yeah, having there be touch that is safe and healing and comforting, in a way that like just the little I know of massage that is like very good for a lot of systems, and psychologically and relaxation and, the tactile piece of how to relax and how to move, can also be another way that the body that has been traumatized can be able to work through and process, touch and through movement and somatic body healing. Good. Next slide.
All right. So I think this is back to me to just do the reminders about what is happening potentially with people with the overlap. And again, maybe those conflicting feelings throughout the pregnancy. I remember during my pregnancy being like, my body is no longer my own. And at times that was frustrating, right? And then if you're already having impact on body image or not feeling empowered, and in control over things because of trauma symptoms, to then add in the relation to what's happening during pregnancy and birthing, and all of this can be, again, overwhelming. But also a time for remarkable growth and opportunities for survivors to really feel like they have worked through things and feel more life affirming, and feeling that a lot of healing can be taking place during these growth periods. Again, the importance of supporting post-traumatic growth, and the importance of finding more and more ways to insert trauma-informed practices. Trauma-informed isn't just individual interactions, right? Systems can be trauma-informed. Organizations can be trauma-informed. And this is a great example with LABBN really highlighting how do we continue to expand providing services that are sensitive, and have a greater awareness of what trauma brings to the table. Next slide, please. I know this slide is overwhelming, and in part it's intended to be because this can be the confluence of all of the different ways that our health can be impacted when we've had lifetime exposure to violence and abuse. So the image on the left is really to identify the pathways to all of the different biological impacts and negative health outcomes that can be a result of trauma. And on the right, I apologize, you cannot read that, and I could not get it clearer. But on the right is really showing the things that are added again to this puzzle when we're working with people that are needing to see obstetricians and gynecologists and have this type of care. Whether it's the teen pregnancy increase, higher ACE score leads to more of those sorts of risks. Whether it's having issues with fertility, looking at other challenges throughout pregnancy that are causing pain and stress. We've talked about depression, not only postpartum, but along the way, again, with feeling like emotions and hormones and control are all over the place. Maybe some of the violence is contributing to needing unnecessary surgical procedures or complicating labor and delivery in other ways. So important to, if it's feeling overwhelming for us to look at this, think about those grounding practices that can help the patient who's likely feeling overwhelmed as well. Next slide. And this is more just for your reference. I like these infographics that really help us kind of, again, see how this can kind of perpetuate itself, and again, how generations upon generations are experiencing these traumas. So looking at how can we better identify what a caregiver's trauma may be, more appropriate places to be looking at where we can do better screenings and again, better referrals. But thinking about just these other ways that children are impacted when a caregiver has untreated trauma. So we talk a lot about making sure that we're working with the family as a whole, and the home visiting model in and of itself is one of the best supports and reinforcements for this at such critical times. So I again applaud you all for the work that you do. Each home, each family, different needs are all very different, but you yourselves are helping to break the cycle right here. Next slide. All right, let's do some breakout rooms, Jessica.
Awesome. So we have a scenario where there is a woman named Lucy who is pregnant, and she's going to be having, I think it's like some thoughts and conversations with her team. So in there might be some areas that maybe the team is falling short on picking up some, maybe some red flags or trauma-informed lens that they may or may not be using with Lucy. Certainly, if there's things that are that you notice that are done well, you can point those out as well, like to be strength-based here. But it was designed to have a few not so great tactics as practice for for noticing that. And I believe it's in your materials and then perhaps in your chat. There, yes, it's also in the chat. Thanks, Terry.
You're welcome.